All right, we're getting started, everyone. Thanks for joining and thanks to the folks on Zoom for zooming in. Anybody who wants to get CME credit, the CME code is 40600 and you can text that to the usual number. And I'm really delighted today that we have a visiting professor, Dr. Patrick Nana-Sinkam from Virginia Commonwealth University, who's spending today and tomorrow with us. We had breakfast today and I learned a lot. Patrick is professor of medicine and the Linda Grandis Blatt Chair in Lung Cancer Research at VCU. He did his internal medicine and chief residency at the University of Michigan, followed by fellowship in pulmonary and critical care at the University of Colorado. He stayed at Colorado as junior faculty for several years and then joined the section of pulmonary allergy, critical care, and sleep at the Ohio State University, rising through the ranks there to become professor with tenure before accepting his current position as section chief of pulmonary and critical care medicine at VCU. His scientific body of work centers around his interests in thoracic malignancies, epigenetics, biomarkers, and the role of microRNAs in oncogenesis. He has extensive funding, including several active grants through the NIH National Center for Advancing Translational Sciences. Under his leadership, VCU is one of the designated sites for the NCI Cancer Screening Research Network Vanguard study that will be conducting clinical and longitudinal studies evaluating novel multi-cancer detection tests, which is pretty exciting. Those of you who have heard me present our speakers at Grand Rounds know that I like to go back to the first publication. And Pat's first publication was in 1991 when it looks like you were a first-year medical student. And it was titled Psychologic Factors Influencing Physical Health in African American College Students in the Journal of Black Psychology. Still relevant. His CV and his record of scholarship reflect the important Bilbo Baggins observation that not all those who wander are lost. And his clear focus on lung cancer, and in particular the role of microRNAs in lung cancer pathogenesis, really is clear in his bibliography, developing during the decade he was at Ohio State and since then at VCU. He's published over 100 peer-reviewed articles in journals including the Blue Journal, JTO, Cancers, and Nature Communications, as well as many book chapters and reviews. Even with his remarkable scholarly productivity and the demands of his current administrative responsibilities, Pat has been really active nationally in the professional organizations. In ATS, he's the immediate past chair of the Thoracic Oncology Assembly. At CHEST, he's been a member of the Lung Cancer Guidelines Writing Committee. He's a member of ASCI and its Committee on Diversity, Equity, and Inclusion. He's involved at ABIM as a member of the Pulmonary Review Committee and at the NCI as a member of the Frederick National Laboratories Advisory Committee. Pat, you're a role model. We're really pleased to have you here. It's an enormous pleasure to welcome you to Yale.
Well, Lynn, thank you so much for that really, really kind introduction. I'd like to thank Lynn Tanui and Naftali Kaminsky and Richard Mathey and so many for the opportunity to be here. It's a true pleasure to be here. I always like to have an opportunity to talk a little bit about what we do. There's nothing that gets me more excited than either talking about what we do or mentoring the next generation. That's kind of what makes me tick. If you wonder what makes me tick, that's what makes me tick. What I want to try to do over the next 40 minutes or so, and I understand that I have a limited amount of time because I want to leave time for questions, is really just tell you a little bit of a story. And this is really about the search for biomarkers in lung cancer. I think it's not lost on anyone in the room that we still have a lot of work to do in lung cancer. We've made tremendous progress, but there's still a lot of work to do. And you're going to hear over and over again about biomarkers and classifiers. So what I want to try to do in 45 minutes is distill it down and give you an idea of where we've been and most importantly, where we're going. I don't have any conflicts, and you've heard that we've had some funding from Stand Up to Cancer, from the NCI, NCATS, and I also lead the training program, the K-12 training program. Here's what we'll talk about. Describe the current state and models of lung cancer risk stratification. That's going to be something that those of you who do this on a daily basis are very familiar with. Those of you who maybe don't do this on a regular basis maybe you'll learn a little something about this concept of risk stratification in lung cancer. I'll talk about some of the current technologies in non-invasive detection of lung cancer. This is what we call the liquid biopsy. What does the liquid biopsy mean? And where are we in terms of liquid biopsies, particularly when it comes to informing clinical decisions, right? At the end of the day, what do we care about? We care about clinical utility. Does it truly change what you do in the clinical setting? And then lastly, I'll just give you an example of how investigators are starting to integrate blood-based testing with radiomics to get a better picture of actual risk. Because I think that's ultimately where we're going to need to go. Combination of clinical variables, imaging, and likely liquid biopsy. So I always like to have some history in my talks. And this is maybe an individual who's familiar to some of you, but may not be familiar to others, okay? This is Thomas Petty. And for those of you who don't know who Thomas Petty was, you know, Tom Petty is really considered one of the grandfathers of pulmonary medicine. He was the chief of pulmonary medicine in the early 70s. He took over the division of Colorado in 1971. He stayed as chief until 1985. But prior to that, he has some real distinctions. He was one of the first, as a resident of the University of Michigan, to ever draw blood gas at the bedside. He did it in the middle of the night as a resident, and he was suspended for doing that, right? True story, true story. This is what you call a trailblazer, a true trailblazer. Fast forward, Tom was responsible, he was a member of a group who actually described ARDS. Fast forward, Tom Petty was part of the group that initiated the initial long-term oxygen treatment trial for COPD. Fast forward, Tom Petty was basically one of those individuals who first talked about the importance of lung cancer screening in high-risk individuals. He talked about this for about the last 40 years. He was talking about this, the importance of finding those people at risk and finding lung cancer early.
By the way, all the registered this year about the awards. Really proud of them.
Absolutely, absolutely. I'm sorry. Can you say that one more? I'm going to repeat it. That we have someone who won a Tom Petty Award. Is that right? Absolutely, absolutely. Congratulations, congratulations. Absolutely. How's this? Better? I'm too tall? Should I like this? Will that help? Okay. Will this help? How's that? Yes? Okay. All right. I'll lean in. So I had the opportunity to get to know Tom Petty in the latter part of his life. Tom succumbed to pulmonary hypertension at the age of 76. He was just short of his 77th birthday. But he worked almost to that last day. And probably a couple of years before he passed, I was at Ohio State at the time. And I received this in the mail. And it was basically a Xerox copy of a monograph. And this was a monograph from Isaac Adler. This is from 1912. This is, by all accounts, considered to be one of the first monographs on lung cancer from 1912. And he signed it there. You can see he signed it there, Tom Petty, and it was signed in pencil. Tom always wrote with pencil, not pen, always with pencil. And it said, from Tom Petty. And there were a couple of things that I pulled out of there. Primary malignant neoplasms of the lungs are among the rarest forms of disease. At that time, we didn't even think about lung cancer. Over 100 years ago, lung cancer was not even on the radar. The overwhelming majority of medical practitioners rarely, if ever, think of a diagnosis of tumor lungs. How far we've come now, where lung cancer screening is something that should be top of mind among high-risk active and former smokers. So just to give you some historical perspective, we've come a long way. So I'll give you a case study, and this is something that is relatively straightforward, but I think it brings up a couple of points. 55-year-old black male presents to inquire about lung cancer screening, past medical history of hypertension, COPD, family history, father had COPD, mother had lung cancer, 25-pack-year smoker, actively smoking. His examination is fairly unremarkable, except with the exception of some distant breath sounds. A couple questions. One is, does he qualify for lung cancer screening? And two, how do you define his risk? What does it truly mean to be at risk? There are some things here that are obvious that he qualifies for lung cancer screening, but there are other things that you would consider and that we need to start to consider beyond age, beyond smoking history when it comes to lung cancer screening. That's one of the points I'm going to make in the first part of this talk. start thinking about factors that go beyond just smoking and just age. That is a very, very blunt tool. So there are many, many challenges in lung cancer diagnosis and treatment. And this just gives you kind of a broad look at all of the challenges that we're facing. But the one we're going to talk about is defining high risk. But there are many others. Diagnostic modalities that minimize risk and address false positivity. What's the best biomarker? I'll tell you right now, I won't be able to tell you what that is. I'm going to give you several biomarkers, several liquid biopsies, and show you the data. Well, eventually, I have to make a decision for yourself, but we don't have the perfect one yet. I think it goes without saying that disparities in lung cancer are incredibly important, improve treatment for early and late disease, and then obviously understanding molecular heterogeneity for a totally different talk. Now, those of you who heard my CV know that I trained at Michigan and I was at Ohio State. And everything you've heard about how much they hate each other is 100% true, okay? I think the Ohio State folks hate the Michigan folks more than the Michigan folks hate the Ohio State folks. But this is what we call risk stratification, all right? This is basically in Ann Arbor at the big house. Ohio State's winning 41-13. And this guy decides that he wants to be the center of the picture. All right, and I say to you, this is risk stratification. Everybody in the room knows what's going to happen to that guy, right? Right? And I say, if only so easy. If we were only so easy to just pick out the person who's going to have lung cancer. It's not this easy. This is obvious to everyone in the room. You can see it from a mile away, right? So let's talk about selection criteria for lung cancer screening. I won't go into great detail, but this is an important study that all of you should know. This is a study by Martin Tamamagi from about 10 years ago in New England Journal of Medicine. And what's really important is that at this time, the criteria for lung cancer screening were really 55, it was just NLST 55 to 74, 55 to 77, 30 pack year smoking. And what they did here is they started to look at other criteria really through the PLCO, right? Prostate, lung, colorectal, ovarian cohort. And they said, well, you know what? If we use a cutoff of greater than 1.3% over 6 years, factoring in additional factors, how does that compare to just NLST criteria? And the important take-home message was that when you consider additional criteria, you actually have a much better sensitivity and positive predictive value. These are some of the early studies to suggest that, hey, you need to look beyond just age and smoking history. And you can see some of the things that are really important. I talked about disparities. Well, odds ratio about 1.5 being African American. Family history of lung cancer, odds ratio of 1.799. Smoking status, 1.3. And that brings up an important point about smoking status. Unfortunately, you have EPIC EMR, we have EPIC EMR. I think everyone would agree that smoking history in EPIC is not very good, right? We would all agree. Sometimes there's no smoking history. We don't talk about, well, at what age did you start smoking? Not just how long, but at what age did you start and how much did you smoke? It's different if you started smoking at 14 versus you started smoking at 25. That's different. We don't factor that in when we start thinking about somebody's risk. So this is another study by Stephanie Kowalczyk, another one that I think is really important. And this is really starting to define people based on the risk of lung cancer death. The other one was just your overall risk of lung cancer, but this is lung cancer death. And what they've done here is very interesting. They took these individuals from NLST and then they put them in quintiles based on their risk for lung cancer death. And they said the lowest quintiles to the highest quintiles. And how does that impact how effective lung cancer screening might be? And they factored in several of these risk factors that you see here. And this is the take-home message: risk determines benefit. Risk determines benefit. In particular, I want you to look at the fact that you have all of these quintiles of individuals, low risk all the way up to what we consider very high risk. So what's a high risk? Greater than about 2% we consider high risk. And then moving across from left to right, you start to see the false positives. You see how the false positive rate starts to drop as you get to the higher quintile. The number of false positives per prevented lung cancer death, right? 65. You see how it drops 65. And then the really important thing that we look at, which is the number needed to screen. One of the criticisms sometimes for lung cancer is, well, you're screening, you have to screen so many people to see benefit in one. Look what happens as you go from the lowest quintile, i.e. the people who have a risk of 0.15 to 0.55, and then you go all the way to people who have a risk of greater than 2%. You start to see how it drops all the way to 161. So what is the other take-home message of this? The other take-home message is the following, and that is not all people who are being screened are the same. We are probably screening individuals who might not benefit from screening, and we're likely missing individuals because we don't necessarily look at them from the perspective of their 6-year risk of death. We just look at smoking and age. We're probably missing individuals out there who don't quite fit in those criteria, who are very high risk, who would actually benefit from being screened. What we like to use is we use something called Should I Screen? And this is what we use in our clinic. And I suspect many of you use this as well. And this is just looking at someone's risk, their actual risk of getting lung cancer over a period of 6 years. And we just quantify it for them. Why do I put up this figure? The reason I put up this figure is because this is what I like to show my patients. When I'm thinking about how do I get that message across to the patients, you are high risk. You got to get screened, number one, and you got to get screened again next year and the year after and the year after. And sometimes what I find is most beneficial is just a picture. I have patients that come in and they say, hey, doc, am I in the green or am I in the red? It's as simple as that. And I say, sir, you're in the red. Okay, I got it. I'm in the red, doc. I'll be back next year. Okay? I say that because sometimes those are the simplest messages are the best messages. So I want to shift gears a little bit and talk about biomarker-driven clinical trials, and in particular, we'll get into liquid biopsies. This is basically a couple of images that show you the following. Here's the take-home message. The take-home message is when you look back to 2004, 2005, very few clinical trials were integrating biomarkers to help in the clinic, to inform the clinical decision. And you can see simply by the trajectory over a period of 13, 14 years, how now we've gotten up close to 50%. 40, 50% of clinical trials have some type of biomarker arm at this point. I think biomarkers are here to stay in terms of informing decisions that are made in the setting of clinical trials. Whether it's a decision, you're looking at prognosis, you're looking at response to therapy, you're looking at a specific drug, these are here to stay. And if you look at really what's happened in terms of trajectory for lung, you can see it there to the right. And you can see how quickly it's going up. So I suspect this will continue to rise, and most lung cancer trials will try to integrate biomarkers in some ancillary fashion to help inform the decision that's being made. So there are multiple approaches to lung cancer detection. And I know I won't talk about all the things that our IP colleagues do. I'm going to talk about a different area. I won't talk necessarily about a lot of the work that's been done by Avi Spear and Mark Lenberg at BU, looking at genomic classifiers in the airway. Different area for different topic, different discussion. But I will talk a little bit about liquid biopsy. Most in the room are probably familiar. They've heard about liquid biopsies. And liquid biopsies really constitute this hodgepodge of potential markers, potential biology in circulation that people are looking at to try to see if they can actually inform the state of the disease that someone has or the potential state of somebody's disease. And that ranges from circulating tumor DNA, cell-free DNA, extracellular vesicles, non-coding RNAs, tumor-educated platelets. And I'm going to touch on a few of those and show you some of that data at this point. So, as I said, liquid biopsy is being used in many, many regards. I'm going to talk about it in the context of risk. I'm going to talk about also in the context of early detection and in the context of actually diagnostic, i.e. someone has an indeterminate lung nodule and you're trying to figure out, is it benign? Is it malignant? What do I do? Those of you who are taking care of patients know when you see someone who has a 12 millimeter nodule, the 12 millimeter nodule. What do I do with that? How do I stratify that person? Do I keep scanning? Do I go and send them to our IP colleagues? Do I get a PET? What do I do in those situations? So we'll talk a little bit about how liquid biopsies can help inform what to do in those situations. There are a multitude of markers. I won't talk about any studies, but this is just to give you an idea of the multitude of markers that are out there for early detection. And you can see that it all depends on the investigator's interest. Some people are very proponents of tumor antigens and autoantibodies. Others are proponents of looking at genes, mRNAs. Others are proponents of miRNAs. And all of these have been tested out and demonstrated, as you can see, some fairly good performance, But you'll see the cohort sizes are not particularly large, number one. And number two, in most of the cases, we don't quite know the clinical utility. And you'll hear me say clinical utility over and over again. And it just means, does it change the decision? Does it truly impact the decision that's going to be made? Here are some of the challenges, because I'm going to talk about microRNAs and mRNAs and proteins and lung cancer. And there are a few things. When it comes to mRNA and mRNAs, one question that comes up is, where do you look? Do you look in extracellular vesicles? And I'll introduce you to EVs. Do you look in whole plasma and serum? I'll show you some data on how we've compared the two to try to figure out where the signal is. The issues of lack of reproducibility. Determining whether the signature is truly derived from the lung. I would argue that it probably doesn't matter, because at the end of the day, if it informs the decision, it informs the decision, right? Doesn't matter if that signal in the blood is truly of lung origin. And then there are other issues, study design, low numbers. And then the last one, which is important, and I won't be able to answer today, is how do you apply it in the community? How do you take all of this great knowledge, this great technology, and get it in Mechanicsville, Virginia, get it in Chillicothe, Ohio, get it in Lawrenceville, Virginia, these places that have very small ambulatory medical centers? How do you get this testing out there? We won't be able to answer that today, but it is something we have to think about if this is ultimately going to be of benefit. This is the first study that I want to just show you, and I'll go relatively quickly through this. This is Samir Hanash's group, really looking at a 4-marker panel. And what they're looking at here is surfactant protein B, CA125, CEA, CK19. And what they've essentially done here is they've looked at about 500 patients. And this is fascinating because they've been able to obtain samples from the PLCO trial and look at these markers prior to the diagnosis of cancer, sequentially, over a period of about 6 years, as you can see in this graph right here, 6 years prior to the diagnosis. So they've had banked samples and they follow these patients longitudinally. And what's fascinating is you can see that even 6 years prior to the diagnosis, you see an area under the curve that's about 0.75. And those of you know that's not fantastic. It's not terrible either to be able, with an area of the curve of 0.75, to actually see a signal 6 years before someone's diagnosis. And as you would anticipate, as you move closer and closer and closer to the diagnosis, you start to see that AUC start to creep up closer and closer to the actual disease being there, all the way to an AUC that's about 0.82 or so. Further, if you kind of look at this and you divide it out in terms of early stage and late stage, you see what you would expect to see. For late stage, seems to perform better 6 years out and all the way in. For early stage, doesn't perform, as you can see in the red line, doesn't perform nearly as well. That's the area that we really need to work on, and that is, how do you do it for early stage disease? It's one thing to be able to diagnose someone with late stage lung cancer by blood test, but hopefully you'd be able to tell for us by some other ways, like a clinical exam and a chest x-ray and so forth. But it's the stage ones and twos we have to really be mindful of developing biomarkers. This is just another way of looking at this. And what's important is, depending on what you're using as your cutoff, for right here in the blue, for 1.7%, using that panel and the criteria for 2012 PLCO, which incorporate a lot of those clinical variables that I was alluding to earlier in the earlier slides, you'd get a 12.6% increased referral of those diagnosed with lung cancer and non-referral of 4,156 of the non-cases. So this is a case in which it's actually starting to shift the people who get referred for lung cancer and the people for lung cancer evaluation and the people who don't get referred. This is a separate study. And this is now looking indifferent. This is in population of individuals, lung cancer detection in symptomatic patients that was in JAM Oncology just a couple of years ago. And what they've done here on the left is you can see they looked at about a total of about 3,000 patients. And what they're comparing in this case is a panel of microRNAs. So we're talking about 15, 14 microRNA signature. And they're looking at the performance in a few different settings. One is here, comparing individuals with lung cancer to everyone else. So these are individuals who have non-tumor lung disease, granulomatous disease, TB, ILD, right? Non-tumor lung disease. People with other types of conditions, of medical conditions. And here what they're doing is comparing, and what they see is you see an area of the curve for this panel of about 0.96. When they compare individuals with lung cancer to those who have non-tumor lung disease, so just this group compared to this group, as you can see right here, this group compared to this group, you see even better performance. And then when you look at comparing, how about just the stage 1 and 2 compared to all these other groups, you see performance of 0.96. So here's an example of a panel, a classifier that has pretty good performance in comparing these various groups. But there are a couple of things. It's retrospective, very heterogeneous population. There were small cell lung cancer patients in here. The controls, the controls were healthy controls. This is one of the pitfalls in some biomarker studies. Some biomarker studies will use healthy controls. Individuals who are non-smokers, they might even be younger. So when we start to think about practicality and application in the clinic, you say, well, wait a minute, those aren't the patients I'm worried about. I'm not worried about a 42-year-old who's never smoked. I'm worried about a 55-year-old who smokes 2 packs a day. That's my control person, right, versus a lung cancer. So fortunately, in most studies, now we don't see that nearly as much, but it is in my mind, a major limitation of some biomarker studies. This is something that you're going to hear about. This is basically a study looking at cell-free DNA fragmentomes. This is work by Delphi, as well as Peter Bach and others who are doing work looking at whether or not specific fragments of DNA in circulation actually can serve as a classifier for lung cancer detection. And here what they've done is they've looked at almost 400 patients in their test group and about a little over 400 in the validation. These are individuals who actually fall in the criteria for being at risk for lung cancer, 50 to 80, 20 pack years. About 129 of them had lung cancer. And what they've done is they've combined genome-wide fragmentation with chromosomal changes. And then they give it what's called a Delphi score. And I won't go into the details of what a Delphi score is, but suffice it to say, what you see here again is fairly good performance. We're talking about areas of the curves that are over 0.90. And I'm just showing you that last figure here in the right-hand corner here. We're pretty good in distinguishing those with cancer from those who do not have a lung cancer diagnosis. And importantly, you see here, the Delphi score is very low for individuals, for example, who have benign nodules, which again is one of our controls, right? Because that starts to address that question of when someone has a nodule, malignant, non-malignant, right? Indeterminate nodule. What can you use to help you stratify who might have the high Delphi score versus the low Delphi score? And this is kind of the model that they're proposing at this point. They're basically proposing that perhaps this is something that could be used among individuals at high risk for lung cancer. I was having a conversation with a few of you earlier today, and we were talking about the fact that we take for granted that it's easy for us to, if somebody comes here, we can get them a screening CT scan, right? But we forget about the fact that one of the primary drivers for the low uptake in lung cancer screening, and I think most people know what the uptake is of people who are at risk for lung cancer who actually get screened in this country, it's about 6%. All right, we're about 6 in Virginia. I think here in Connecticut, you're probably in the teens is kind of my guess, right? But overall, we don't do that well. Massachusetts might be about 16%. There are many factors, but one factor is that many people don't have access to lung cancer screening. They're not even near a center that does lung cancer screening. That is incredibly important. So this is where perhaps if you develop a cost-effective, accessible blood test, this may not necessarily be the one, but can you start to identify those people who you need to reach out to and find a way to get them screened if possible? All right. So most in the room are probably familiar with extracellular vesicles. You've heard about them in one way, shape, or form, right? These are really, really interesting particles that tend to be in any bodily fluid. They're released by any organ. They're highly, highly dynamic. We call them extracellular vesicles. You've probably heard the term exosomes. You've heard the term microvesicles. You've heard the term apoptotic bodies. And even to this day, we haven't been able to completely settle on how you distinguish an exosome from a microvesicle and so forth. People use certain cell surface markers, size, appearance, and so forth, but it's still a little bit foggy at this point. So we've been in this space, and this is an example using nanoparticle tracking analysis and on some cell lines of these particles that are constantly moving around in circulation. You can find them we found them even in exhaled breath condensate, urine, for example, pancreatic fluid, obviously blood, sputum, just about in any secreted fluid, you can find these extracellular vesicles. We've done them in saliva even as well. They're about 40 nanometers in size, up to 1 micron, depending. And the important point is they have broad biological function, okay? Not only locally in the immediate environment, but also in the macro environment as well. So this research here, this is Melissa Piper. Melissa is a dear friend who's now passed. Melissa passed of colon cancer, undiagnosed, no real blood test at the time, and developed DVT on a flight going to a conference, got a workup, and had a colon cancer, okay? Think about if she'd had a blood test, if there was some blood test that existed to be screened, had a family history, and so forth. But I put her up here because this just shows, and this is for the early career investigators and the fellows, how sometimes just a conversation over coffee about research can spark something. I was sitting in my office one day. Melissa was a PhD. She was trained in hematology. Most of her research had been in hematology. And she came into my office one day, and this was in 2006. And she said, you know, I was just at the American Society of Hematology, the ASH meeting, and I heard about these things called extracellular vesicles. People don't really know what they do. People don't know what's inside of them. Some people think that they're just shed from cells and it's just represents a debris that the cell no longer needs. We just don't even know. And at the time we had been doing microRNA work. We started doing microRNA work in 2006. And she said, I have a funny feeling that microRNAs are in there. And I said, really? And she said, yeah, I think so. We should look. I said, okay, hey, I'll whatever you say, I'll do. Let's go for it. Why not? Let's try. So we recruited a bunch of healthy controls, college students. We didn't coerce them. So just if there are any IRB people in here, we did not, okay? And we just went ahead and did some sequencing, looked for microRNAs. We also did some flow cytometry because we wanted to figure out where these vesicles, at the time we were calling them microvesicles because that was the terminology at the time. And sure enough, we found microRNAs in there. We looked to the literature and no one had shown that. I said, oh, this is this is our eureka moment. This is it. We're going to be famous. This is it. So we write the paper up very quickly and we send it out. Rejection, 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 rejection. Probably 6, maybe. You guys are crazy. This doesn't make any sense. No way. Everybody knows that microRNAs do exist in extracellular vesicles, by the way. So, okay. And then eventually somebody published right before us, and I think we had the 3rd or 4th publication. But the point was that this was just an idea, spontaneous. It wasn't planned. It was over coffee. We just had a conversation, and lo and behold, we found an avenue for research that we then took on and led to us developing some liquid biopsies of microRNA. So the point is, there's no idea that's too far out left field, all right? When you hear something that sounds really very, very different, instead of saying, yeah, I don't think so, I'm not interested, I would encourage you to lean in and listen, because every once in a while there might be something that's really brilliant that comes out of nowhere. And I give all the credit to Melissa. This is just a brilliant, brilliant idea. There are multiple, at this point, studies with microRNAs. And much like what I showed you before, they have all types of sensitivity and specificity. The big issue is these are all really, really small studies, and none of them have reached clinical application. I mentioned extracellular vesicles, and importantly, we've done a lot of work in this space, and I want to have time to go through all the work we've done in this space, but suffice it to say, we know now that extracellular vesicles have been implicated in one way, shape, or form in almost every hallmark of cancer. Recall back to some of the original papers by Bob Weinberg and others that there are certain hallmarks of a cancer, right? Cancers tend to have unchecked proliferation. They tend to be resistant to apoptosis. They tend to promote angiogenesis and on and on and on. So suffice it to say that EVs, extracellular vesicles, have been implicated in almost every one of those hallmarks. So this is some work that we did. And I mentioned earlier that we wanted to figure out where these microRNAs were. Were they just in the vesicles? Were they outside of the vesicles? Were they somewhere else attached to agoproteins, perhaps, in plasma? And so this is a very small study. This is kind of how we first got started. And what we looked here is we basically looked at individuals, small number, and I'll show you larger numbers later, but small numbers of people with benign nodules versus individuals with stage 1 lung cancers. Controlled, pretty controlled for everything else. And what we did was we systematically went ahead and did sequencing. And we sequenced the whole plasma, we sequenced the extracellular vesicles, and we sequenced the plasma when we had actually removed the extracellular vesicles. We did all three. And we tried to figure out where are these microRNAs truly, right? And what we found was basically, it appeared that they were primarily, in this case, in the extracellular vesicles. Here are some of the mirrors that we found. And there are a couple that I'm going to highlight for you. I'm going to highlight 411, and we also looked at mRNAs and TKTL1. Just want you to keep those in mind. This is an example of how it looks. So what you see here, I think you can see the difference as you go from left to right. Whole plasma, whole plasma, you can see essentially not much of a difference. When you get into just the EV fraction, you can see start to see differences for this particular microRNA. And I'm going to talk about this microRNA and its function tomorrow in the research conference, so I can get into its actionable function and how it works and how we're actually using it as a targeted therapeutic as well. And then plasma without the exosome. So one of the challenges that we've come up against is what are the best ways to capture these extracellular vesicles out of circulation? Those of you who do this work know that there are many ways to do this. You can use traditional ultracentrifugation, high spin, and then eventually you get the vesicles that come to the bottom. Others, there are kits that exist, all right? But there are no real technologies. At this time, there were no technologies to actually find specific vesicles out of circulation, right? If you think about the fact that there are trillions of vesicles in circulation, how am I going to go about finding vesicles that are just enriched in a specific microRNA? Vesicles that are enriched in a particular mRNA, right? It's almost like I use the analogy of trying to find a specific seashell in the ocean. I need this one, but I got to go through millions and billions of others to find this one. Can I come up with some way to capture just that specific seashell? So we developed, in collaboration with the folks at Ohio State, a nanochip. This is a chip that's essentially designed to capture vesicles out of circulation and to characterize what's inside of those vesicles. And I'll show you how that works. And this is through work with a colleague of mine, Jim Lee, and we're still colleagues to this day. Essentially what you have is you have a glass slide that's pre-coated with artificial extracellular vesicles. Those extracellular vesicles are also pre-packaged with a molecular probe, all right? And the vesicles themselves have a charge in such a way that they connect with vesicles that are passed over them. These are vesicles out of circulation that are passed over them. When they connect, which I will show you, the molecular probe actually gets internalized by that vesicle. And if it finds that specific sequence for whatever mRNA or microRNA, that probe will open or unzipper, and then it will fluoresce. So by the fluorescence, you will know that that particular mRNA or microRNA is in that vesicle. And we've done work where we've actually looked all the way to a point of distinguishing even by a single base pair. So we know it's accurate. We know even it defines that particular mRNA or mRNA down to a single base pair. And this is kind of what it looks like. So you have basically it's TCLN, tethered cationic liponanoplex. And what you essentially see here is initially before we load and then after we load the exosomes. You can actually see that the exosomes are there. And for each nanoparticle that we have preloaded on the chip, it captures about 10 exosomes that we pass over it. And this is another way to show it. And what you can see here, this is some electron microscopy that essentially shows you, here's a lung cancer patient exosome, here's a normal donor exosome, here's the lipoplex that's preloaded on the slide, as I mentioned. And what you're seeing is real close up that the exosome is actually binding to that lipoplex nanoparticle. And we did this basically just to prove this is really happening. It's not just a bunch of cartoons. It's actually happening. And this is what I mentioned. This is the signal. So we actually created single, double, triple mutations of a sequence, packaged them into artificial exosomes, passed them over our nanochip and said, how well does it distinguish between the actual sequence versus if you have a single base pair, 2 base pairs, 3 base pairs. I think you can see there in terms of the fluorescence, you get plenty with the wild type. The minute you go to even 1 base pair that's off, you don't get the signal anymore, which means that yes, it binds, yes, it gets taken up, but it doesn't recognize a sequence, so it doesn't open and fluoresce. This is one study that we've done where we've looked in benign and indeterminate nodules and stage 1 lung cancer, no nodules, advanced cancer, benign, and stage 1 cancer. Here's an example. So this is what you're seeing, and this is for a couple of other markers. TTF1, which I think most people know what TTF1 is for the lung, right? And TKTL1, which is one of the markers we found in our sequencing. And as you move from left to right, hopefully you can appreciate the fact you can see as you move from no nodule to benign indeterminate pulmonary nodules, and then stage 1A and B cancer and advanced cancer, you can see kind of the difference in the sequence, in the image. Big differences in terms of fluorescence, and then we quantify that fluorescence. And here are some RLC curves, and we're able to show that stage 1 versus smoking controls, we could get AUC as close to 0.94. Here's some other unpublished work that we're doing now. We're also using this for surveillance for individuals who are post-resection. And what you can see as you move from left to right, each of these are individual patients. You can see the drop in the signal 1 month, 7 months, 12 months after the resection, 1 month, 12 months in this patient. Fortunately, we didn't have consistent blood samples from each of these patients. This is an interesting one where this patient, the signal went back up 18 months. It so happened that they had a recurrence at that time. So really being able to use this signal to follow patients in the setting of surveillance. I'm going to actually advance to this. We're also doing the same thing for small cell lung cancer. We've done nanostring, we've also done sequencing, trying to identify markers for small cell, which can be very, very hard to do early, and more importantly, can be very hard when it comes to surveillance. Nobody really knows how to do proper surveillance in small cell. We have a general idea of when the recurrence happens, but nobody really knows how often do you follow these patients? How do you know if their disease is coming back? How do you know how much residual disease they have? So we've done the same thing here. And this is the cohort that we're looking at. And what we found here is we found a specific microRNA in circulation that seems to pretty well distinguish at least small cell from the other histologies, but not so good in distinguishing small cell from controls. We didn't identify a really great marker. So what we did is we moved to a different nanochip. And what we did here is we designed a nanochip that now does 2 things. This can actually identify microRNA and mRNA, and actually a protein that may be on the surface of the extracellular vesicle. And we can do that simultaneously by essentially designing, instead of bicationic, it's basically with an antibody that's on the surface of our extracellular vesicles that are preloaded on the slide. And here's an example. And what you can see here is looking at high-risk controls versus small cell. What we're looking at essentially is a combination of microRNAs, mRNAs, and M proteins. So we have a nanochip that can actually characterize in circulation what the EV has in terms of an mRNA that's in it, an miRNA that's in it, and a protein that's on the surface. So this gets to the following point, and that is, in all likelihood, It's not going to be just an mRNA. It's not going to be just an mRNA. It's not going to be just a protein. It's probably going to be a combination. Some type of combination will lead us to the eventual ideal liquid biopsy marker. This is just another example showing that multi-detection of protein mRNAs and EVs is the way to go. And this is another study that was an ACS Nano. And then lastly, this is a study by Michael Cameron and others and the late Pierre Messiaen. For those who don't know Pierre Messiaen, Pierre was a very dear colleague of ours, a leader, an absolute leader in this space. And I thought it appropriate to show some of the work that he did that was really important in moving the field forward. And Pierre, who was at Vanderbilt, was a big proponent of this idea of integrating blood-based testing with clinical variables with imaging, and that the true biomarker was in those three. That was the way to basically do this. And this is a study that he did demonstrating essentially that you could get really good performance using this combined biomarker compared to our Mayo risk in individuals with indeterminate pulmonary nodules. Lastly, I just want to talk about a couple big studies that we're doing right now. And this really gets at a couple of things, and that is disparities in lung cancer and how we are now moving towards biomarkers really to help inform and hopefully narrow some of the disparities that exist. This is a study. We are a center. We have a P20, a P grant, and Rob Wen, Shanita Hughes-Halbert, and Victoria Seawalt lead that. I lead the first project with Rob Wen, and what we're now looking at is this idea of epigenetic changes in circulation, PRMT, as well as microRNAs, combined with environmental factors. This gets at an even higher level of complexity. Somebody's risk for lung cancer is probably maybe something genetic, maybe something epigenetic, social determinants, the environment, the stress, cortisol levels. There are probably a lot of things. And that's no small undertaking to try to now bring all of this together to get an even more complex picture or comprehensive picture of what someone's true risk of having lung cancer. This is the second thing. We're a member of the Stand Up to Cancer. We have a Stand Up to Cancer grant that we are working on right now, very similar. The first project is really focused on developing true infrastructure. I talked a lot about biomarkers, but then there's the other piece. It's the infrastructure. How do you get people screened? How do you reach certain marginalized communities? And our aim is really about that. The second aim is really testing out a separate genetic risk score for lung cancer among African-American males. Why African-American males? They're the ones who are diagnosed at a younger age and smoke less, and they get screened less. When we start to think about the real disparities that exist, that is a population that we have to focus on, okay? This is a set of the population that's dying unnecessarily because they're not being screened for lung cancer. Very, very important, and we're focusing on that. And then lastly, we were just recently awarded a UG1 to be part of the Cancer Screening Network. This is broader. This is about multi-cancer detection tests. You're going to hear about these a lot, MCDs. These are tests that essentially either use DNA methylation or DNA fragmentation, looking for cancer in circulation. They have not reached clinical application because we don't know the clinical utility. We're one of 7 centers. We're going to test it in 1,600 patients in the state of Virginia. All the centers together, 24,000 across the country, testing clinical utility of a multi-cancer detection test. What does it do to the algorithm for a primary care physician? How does it inform that algorithm? Colonoscopy, mammography, lung cancer screening. We have to figure out ultimately if there's a place for this type of blood test in practice. So I've gone through a whole lot of things in a relatively short period of time. We talked about risk assessment, and I hope I got across to you, got to go beyond age and smoking. It's much more complicated than that. We talked about integration of clinical assessment with liquid biopsies, showed you some of the technologies that we're doing, including ones that we've been working on at this point, we continue to do. I think I also gave you the point that classifiers that integrate multiple platforms, clinical information imaging, are likely to be the most successful. And then, of course, clinical utility is absolutely important to clinical decision-making. And with that, I just want to thank my team. I have a whole team of individuals that I've had the pleasure of working with. Giovanni Nagita, who's been great in terms of bioinformatics and has helped us with some of this work. Kai Wang at Institute of Systems Biology, Julia Romano, Robin Toft, and then several of my collaborators, including Harvey Pass and Jim Lee and Mario Kunzo and Michele Seviano. And with that, I'll stop, and I thank you so much for your time.
few minutes for questions.
There's one up there.
Thank you very much for that fabulous talk. It's really inspiring, interesting. I was wondering, are we at a point yet where we have knowledge of sort of the utility of different panels of biomarkers, let's say for people with COPD with lung nodules or lung cancers versus COPD without the lung cancer? Is there, is that a direction that this field is going in where you can then screen people at risk for whatever the various risk factors are,
Yeah.
and then cull out who is most likely to get lung cancer?
Yeah, thank you for the question. So the question really had to do with whether or not some of these biomarker studies are really focusing in on these specific populations of patients, particularly those who have COPD and might have a lung nodule, if I understand correctly, and whether or not these panels can be applied in that specific population. Did I understand your question correctly? Yeah, the answer is yes. More and more, these studies are becoming more sophisticated in looking at what we consider to be truly the high-risk patient. And we've kind of evolved over time. Before, we were looking at just anybody who's a smoker, healthy controls, people are smokers. But now we're recognizing that as we start to risk stratify these patients, those individuals who have, for example, COPD, because we know that on a CT scan, if you have evidence, radiographic evidence of emphysema, the odds ratio is 2 to 3, something along those lines for lung cancer. Those are exactly the people that we have to be screening. So the answer is yes. There are several now studies that are ongoing. Important point is we just haven't really reached full clinical utility. And the thing that I think about is how do you get these types of biomarkers or classifiers to the people who most need them in the rural communities and urban communities? And I don't have an answer for that. I wish I did, but that's where we have to be, because they're the ones who are disproportionately impacted by a lot of these malignancies. So thank you for the question.
So thank you for a fantastic talk. So I'm curious about the last part of your talk when you were focusing on health disparities.
Yeah.
And how to tie that into the rest of your talk, in the sense that I know a lot of the studies that we do aren't really representative of the population.
Right.
So when we're looking at things like biomarkers and the other markers that you're using to identify risk, how representative are those samples?
Yeah.
And do we have any reason to be concerned that people from different ethnic backgrounds might have different arrays of biomarkers that need to be accounted for?
Yeah. So really the question here has to do with really how do you approach the fact that many studies, classifier studies, biomarker studies, have quite frankly included mostly homogeneous populations. They haven't really included populations that are historically impacted by many of these diseases. And how do you reconcile that, and how will that inform design of future studies? And so the reason I put that in there is because we are now starting to think in that way. We're starting to go beyond what I showed you before, because most of those studies really have very homogeneous populations. And now we're starting to say, okay, well, who do we need to focus on? Well, one population are African-American males. And that's why now we're actually working on this particular grant to develop a genetic risk score that then gets coupled with other clinical variables and environmental factors to truly characterize risk in that population. And that's why I put it up there, because that's part of the direction we're going in. The other thing that I would add is that I'm giving a talk tomorrow where we're actually looking at another level in these microRNAs in circulation. We're looking at what we call post-transcriptional modifications. And what we have seen is that when we look at post-transcriptional modifications, which goes beyond just absolute microRNAs, we actually see classifiers that are distinct between African Americans and Caucasians, and even when it comes to prognosis and overall survival. So we are trying to move in that direction. Yeah.
Thank you for a really interesting talk, and a little bit of a shameless plug for my grand rounds in a couple of weeks. I'll be talking about radiomics and computer-aided nodule detection. So
Perfect.
we'll have the whole thing put together.
Awesome.
I guess I had a couple of questions. One, we're primarily talking about high-risk population, lung cancer screening, find a nodule, kind of do you use liquid biomarkers to help to pre-risk stratify, or once you have the nodule to further help with risk stratification and characterization? So I'd wonder how you might apply the work you're doing to incidentally discovered lung nodules, picking up somebody PE trauma, has a lung nodule, given that this is not necessarily that high-risk population, I can imagine people wanting to use your liquid biopsy technologies in this population and how you think that will need to factor into clinical decision-making. And then the other question I had is whether you have any data regarding the correlation between kind of radiomics classifiers and the biomarkers that you're establishing. Can, in essence, we use deep learning to try to achieve the same result as a liquid biomarker?
Yeah, so let me take the second question first, if I could. The second question had to do really with looking at radiomics and where does radiomics kind of fit in terms of correlating with some of the biomarkers that we're trying to develop, and whether or not through machine learning can you get to a point where, if I understand correctly your question, you actually reach similar performance with the imaging by using things like machine learning and artificial intelligence to what we have in the biomarker. Did I understand your question correctly? Yep. So I think it goes with saying, you know, that there's the Sybil trial that was done and was published just recently in the last year and a half out of Harvard. And that was a study that was really looking at radiographic imaging and developing an algorithm using artificial intelligence and machine learning, where based on the image, you could predict essentially the risks of someone who's going to get lung cancer. This is independent of whether they're a smoker, and it's not really dependent on age, just based on certain patterns, which we don't know. On that CT scan, you can actually figure out somebody's 1 year, 3 year, 4, I think it went out to 6 years, if I'm not mistaken, risk of getting a lung cancer. So the short answer is yes, that we probably also have an opportunity by using artificial intelligence and more sophisticated machine learning, using the imaging that we have to probably reach equal performance, right? And remind me the first question. Incidental. So whether or not this particular technology could be applied in incidental nodules. Is there a place for it? I suppose there is. What I would say, though, is so many incidental nodules are likely benign. Most of those are very, very benign. So I suspect the study design would need to be a little bit different. I can't assume that our markers would work. I don't know that they would at all. I think that from my perspective, I think it's all about the stages in which you do this. And I think right now, I'm kind of focused more on the highest risk patients and just trying to minimize unnecessary surgeries, unnecessary biopsies, missing indeterminate nodules that are then going to triple in size is kind of where I'm focusing on. But I think there's absolutely a place for incidental nodules at all. And there's a little bit of literature, which I didn't show here, that's focusing on that particular population as well. Yeah, sure.
All right, we're actually at the, Naftali, did you have a question? Sorry.
I can just, I'm gonna press
Yeah.
for a second, because you said multiple times, our problem is to get these tests to the people who need them.
Yeah.
And then you said, I don't know how to do it. So I'm gonna ask you actually, because there's a lot of younger people and we want them to learn to be bold and innovative, as you've
Sure.
been. I think the first time we met was 2006.
That's about right.
We met with Melissa. Right?
Yeah.
And then,
Absolutely. Yeah.
And so how would you imagine a
Yeah.
process that we do get to the highest? And I think it starts, actually, our problem is to get even the people who just need CT scan screening. We're not getting that. So,
Yeah.
so how do we imagine a system that we actually get the people who need to
Yeah.
be?
So, I mean, I don't have the perfect answer, but I'll give it a shot. So I think it really comes down to a couple things. One is, we have to be very, very mindful of the cost effectiveness, the efficiency, and the ease with which you can test for these types of classifiers. It was great that I showed the nanochip and all of that, but being realistic, how are you going to use a nanochip in certain parts of the state or certain parts of the country? My feeling has always been that if we can get to a point where we can develop a classifier that uses readily accessible technologies like PCR, I think something like PCR would probably be one of the best ways that we could go with this type of technology ultimately. I think that there's also going to be a need to design our studies differently. So Most of the time, our studies are designed in such a way that everything is central in an academic medical center. That's what we do. It's what we know. I think in order for any of these types of technologies to be successful, we have to actually, Naftali, design them with the community in mind, right? These are the types of things that have to be done in FQHCs. They have to figure out, can you do it there? Can you do it in rural community hospitals? Can you not do it? But again, I think we probably have to move towards a simpler, easier technology. I don't think we're there yet. I can't sequence everybody. I can't do a nanochip on everyone. I'd like to be able to do that. Can't do that. So I don't know. I don't know if you have thoughts about that, but I think that's kind of where we are.
All right. Thank you so much.
You.
That was an
Appreciate it. Thank
amazing
you.
talk.